Yes, a very good afternoon and many thanks for staying with us right here on NTV Uganda. My name is Romeo Biziku and I come to you yet again with another pertinent conversation. Increasingly, poor quality of care has been found to be the major underlying factor for what? Increased maternal and perinatal mortality. Globally, millions of patients are harmed while receiving care, making patient safety an urgent and global public health concern. In addition, 34 million adverse events occur in hospitals and most patient harm is actually avoidable. While still is the COVID-19 pandemic which has disrupted essential health services and reduced access and availability of essential drugs. In addition, it has amplified the disparities and inequities, rendering marginalized and disadvantaged women more prone to poor quality of care and associated mental health conditions. A lack of focus on patient safety has major financial implications for countries, including on health systems, communities and societies. The cost of prevention is actually typically much lower than the cost of harm. In Uganda, maternal mortality rate is around 93. Women die. So do know that we are also grappling with perinatal deaths of 20 children dying by every 1,000 live births. That's what we do know right here on Morning at NTV. Did you know that worldwide over 2 million children are killed during birth? Yes, we suffer stillbirths of over 2 million, and that is a perinatal deaths of about 1.8 million deaths, courtesy of poor access to essential health services right here in Uganda. To expand more on this and so much more, I'm joined by Dr. Olive Mugisa, the Family Health and Population Advisor at the World Health Organization, and Ruth Nakanja, the Executive Director of the Sickle Cell Association, both of whom join me right now for this very pertinent conversation on World Patient Day. One of those World Patient Day was actually earmarked in 2019 by the 72nd World Health Organization, or Assembly in that regard, to raise awareness on the global issues affecting maternal and newborn health care in that regard. A very good afternoon, Dr. Olive Mugisa and also Ruth Nakanja. Thank you for joining us on this auspicious day, World Patient Safety Day.
Thank you.
All right. First off, let's kickstart this conversation by explaining to the viewer what is the significance of actually observing World Patient Safety Day.
It's going to be important for us to appreciate that this is a global movement. And of course here in Uganda, the importance worldwide is to make sure that we raise awareness over this selected theme in healthcare that seems to be causing a huge concern within public health arena. So this time around, and I think all of you agree, that maternal and newborn health outcomes have become a major concern for everybody, including individuals down there in the community, but also government and partners and all ministries. And we need to address it. We need to raise concern about it. We need to raise awareness about it. We need to mobilize people into this total community commitment into ensuring that women, their pregnancies, their newborns survive this total process of pregnancy. Because as you all agree, pregnancy should really be a normal event with the outcome of a normal mother and a normal baby. And when pregnancy is in the house, everybody's happy. And so we should also be happy to carry a pregnant mother up to the end and really have a safe mother delivering a live baby. And so we must create this awareness amongst communities and individuals from the lowest to the highest level to say, actually pregnancy is risky. And things may not end up as we desire because of various problems on the way which may occur. We need to ensure that leaders at all levels commit to this kind of issue and understand it more so that they invest more into ensuring that we sustain mothers and their newborns healthy. We must create the necessary response for government offices, government sectors to put in place those systems that will save mothers and newborns. And the Ministry of Health cannot do that alone. We are calling upon local government, Ministry of Finance, Ministry of Education, name it, to create that environment. But creating an environment takes a lot. It takes more investment. It takes the Minister of Finance and, of course, the Mother Ministry to efficiently use the available resources, but also increase. Because of the increased population that we have, we need to invest better. And we need to mobilize everybody to identify what their roles and responsibilities are and ensure that we put a total system into place. And that's why the World Health Organization and global health partners have called upon countries to create this awareness and call for action at all levels of care, at all levels of community, to make sure that we respond appropriately. We begin to discuss this at the level of the community and where actions must be taken.
That is Dr. Olive Mugisa. She is the Family Health and Population Advisor at the World Health Organization. We are talking about World Patient Safety Day. In Uganda here, mortality rates have increased, courtesy of information coming in from the United Nations Population Fund. They conducted a study between 2019, that is January and June, and also 2020, during the onset of the COVID-19 pandemic, that is January and June. And they noticed an uptick of maternal mortality rates taking center stage within this country. Between January and June of 2020, yes, we did record some 1,202 mothers succumbing to various injuries as a result of delivery. But in 2019, that number was around 1,085. We also have a lot of aggregations in that regard. We do know most of those numbers were at Kawempe National Referral Hospital. So we'd like to know, why are there more mortality rates being registered right here in the country? Dr. Olive, why are we in this state of quagmire? Could it be the onset of the COVID-19 pandemic, the measures we put in place to stop the spread of COVID-19, in that pregnant mothers couldn't access essential health services relating to maternal and newborn care during the COVID-19 pandemic?
Thank you, Romeo. And as you've just said, when the lockdowns began, when the awareness around the pandemic and what it really means started, and the lockdown systems started for the entire country, it meant that everybody is touched. Everybody must adhere to the government standing operating procedures for making sure that we prevent this infection from spreading. And that included, as you all remember, that everybody went back home. Everybody left their economic, incomes, and we were told not to move. In the beginning, that is what it was.
So that's why the mortality rates increased between January and June.
Which means, yes, that people cannot reach in time. Even as systems are put up in the districts to facilitate mothers to move, because the systems operating in this kind of pandemic are not exactly the same as when there is no lockdown, when we can access anybody to transport us, border borders are on lock, taxis are on lock, public systems are on lock. Those limited responses at district level cannot satisfy the numbers that are moving, because we didn't stop the pregnancies and their growth and mothers to be in labor. So for them, they continued at the pace, the normal pace which takes them. But the systems did not come into place in the normal way. The good thing is that this was realized early. The Ministry of Health and partners raised this to the government leadership, and they started quickly addressing how do we make sure that mothers who are in labor, who are obviously pregnant, I think that's how it was put, must be facilitated to move to the health facilities. Now, in addition to that, for Kawempe, as you know, Kawempe is almost the national level response hospital for maternal and newborn. And it, by the way, in the world, it's the highest labor ward output. So we are dealing with very big numbers in Kawempe. Many mothers with various complications being referred into Kawempe, but also from different districts, from the entire country. mothers with complications require different types of responses and require a lot from the system, ranging from blood availability, because many of them come with bleeding complications. Many of them come when babies are already anyway dead because of those long distances they had to travel. Many of them come when their complications, which started maybe 24 hours ago, have worsened, and therefore the mother is even more sick than when she started moving from Jinja, from Kasese, name it. They come from all districts into Kawempe. That means the number per day which Kawempe has to handle is many more times than the health workers who are found there. If you can imagine, they have to receive all these people, and their numbers did not increase in the same manner. Remember, they have to manage Kawempe, they also have to manage the women's hospital, and that means staff has been divided. Specialized services from anesthetists, from people who manage children with very serious problems, these newborns, are not increasing at the same rate. Neither are the specialists or midwives increasing at the same rate. Yet the demand really increased because this was the national, and it is the national reference point. But mothers are coming in late from all angles. They are finding that health workers are not adequate in numbers. They are very tired. Even as they're changing shifts, they're not enough. The PPE, what prevents infection for the health worker themselves? Their supplies, their equipment means it gets very quickly used up. And we have to make sure that there is a system which can hold these numbers. And all the service providers, ranging from the national medical stores to the blood bank, are still put at a very high demand, and they must respond to this high number. And so you can see that with this kind of state, where we are not sure that even the transport systems set up, even from our nearest villages, are in place, we experienced this high mortality, high morbidity, because of the disruption at all the lower levels of care.
All right. Thank you very much, Dr. Olive Sembutier Mugisa. She is the Family Health and Population Advisor at the World Health Organization. And we're talking about World Patient Safety Day, a day that was earmarked in 2019 by the World Health Assembly. Yes, the 72nd World Health Assembly. We do know that 34 million adverse events have been recorded as a result of poor maternal and newborn care. We also do know that in Uganda here, 93 mothers are lost out of every 100,000 live births. That is against the United Nations targets of keeping it at bay around 24 deaths out of every 100,000 live births. We are also losing 20 newborns out of every 1,000 live births in that regard, against the United Nations recommendation of keeping it at 10 only 10 deaths out of every 1,000 young newly borns being born in that regard. Did you also know that Ugandans are giving birth to over nearly 2 million young babies every year? And all over worldwide, it's 120 million young newlyborns being born actually all over the world. Meaning, are we putting in place maternal and newborn health interventions that will go a long way to handle the influx of babies in the world? Let me also bring in, that is Ruth Nakanja, the Executive Director for the Sickle Cell Association. You do know how badly they've been affected, especially mothers who are anemic in that regard. Ruth Nakanja, thank you for joining us right here on this auspicious occasion.
Thank you so much for hosting me.
All right. You did hear my obligations. Please, you can remove it.
I can remove the mask.
Yes, we are giving
social distance.
Yes, we are giving birth to nearly 2 million children all over the world. 120 million babies are born every year.
Yes.
In the case of Uganda, where nearly 2 million children are born, do you think government has put in place enough maternal and newborn care facilities or interventions to be able to handle this influx of babies being born?
No, I think government, we thank them for what they have done, but I don't think it's enough yet.
Right.
Because what they haven't looked into the issues of people who have those other chronic illnesses. For example, me, I come from Sickle Cell Association. The people that have sickle cell disease really face a big challenge when they are pregnant, especially those that are not in Kampala, because most of the sickle cell clinics are around Kampala. And I think we have about five or six in the regional referral hospitals. So, and those only give a day in a week where they see sickle cell patients. So you can imagine that these people are all over the country. We know that annually we get 25,000 babies born with sickle cell disease in Uganda. So, and we lose about 80% of those before they celebrate their 5th birthday. So, but those few that survive get pregnant along the way because they are normal, they are humans. So you can imagine how they suffer out there where there is no clinic and there is no staff who can even understand how to handle them. Some of them are actually sent away when they come to a facility. Probably they've come to have family planning before even pregnancy. They don't want to get pregnant, so they have gone to get contraceptives and they are sent away because the health workers don't know what works for them. There's no research that has been done here, so I would rather not give you than hurting you or harming you in the process. So there's a lot that needs to be done because there are many conditions besides sickle cell disease, and yet we see even those in the population that is taken to be fine or okay, there are also challenges. So, and the major challenges in sickle cell disease, first of all, is contraception and sickle cell disease. Then we have the anemia. Naturally, they are anemic. And then the awareness, there is a lot of stigma that is attached to sickle cell disease, both at family level, individual level, facility, community, everywhere. There's a lot of stigma.
Even the health facilities are stigmatizing or discriminating against people with sickle cell anemia.
Yes, yes, they do. Because
people who are supposed to help you.
People who are supposed to help you. Someone, you tell someone, I've come here to get maybe contraceptives. I have sickle cell. What? No, 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 no. For me, I would rather not handle you. Please go to another facility. I don't even want to begin with you. Why? Because someone doesn't have the information of how to handle you, so he would rather not harm you, so he sends you to another facility. And then other people will ask you, normally when you fall sick, what do they give you? So if you're in position to narrate how they treat you, then that person will treat you according to what you have told them. So there's no diagnosis. Maybe this time it's not the same the same problem that is supposed to be treating, but he will treat you according to what you have said. So you can imagine there are a lot of challenges there. Then we expect a lot of stillbirth at every stage.
Prenatal deaths.
Prenatal deaths, yes. You expect them in sickle cell disease. And then sometimes
what about neonatal deaths
expect
after giving birth, those complications that come about?
Yes, those are also likely. Sometimes it's prematures that are gotten, and there are a lot of miscarriages as well. Those are some of the complications attached to sickle cell disease and pregnancy. Then, of course, the issue of blood. When you talk about COVID-19, you remember that time where we didn't have blood in the country, the oxygen was all attached to COVID patients, and those were months that were very cold. June, July are the worst months for sickle cell patients, and around November to January, because that's a cold season. So you expect very many pneumonias. And now this was a time when oxygen was basically for COVID-19 patients. So we don't know how many we lost during that time. So, but when we
And
talk
that is the biggest problem that we've noticed right here at NMG. There is no aggregation of data concerning how many prenatal deaths we've registered here in Uganda, how many neonatal deaths have been registered here in Uganda, and how many mortality rates, meaning how many mothers we've lost during this period of the pandemic. There are no aggregations, simply because the government is sleeping on their job. When we say 93 mothers are being killed out of every 100,000 live births, that is a recipe for disaster, because it's against the target coming in from the United Nations, or the newborn action plan of keeping it at least 24 deaths per every 100,000 live births. So you are actually, before this conversation, you did actually acquaint me with your story. You did give birth 5 years ago, but there were some challenges that were registered in that regard, because we talked about some of the risk factors pushing maternal mortality rates, perinatal deaths, and also neonatal deaths. And one of them is COVID-19. Another could be some who have underlying health illnesses, maybe like sickle cell anemia and so forth. But then we also do have the rude midwives. During delivery, they actually use needles to actually prick these mothers who are giving birth so that they could do what they want, slapping them, all these other issues, psychological trauma that they are levying on our mothers in that regard. Did this happen during your experience 5 years ago?
Yes, 5 years ago, I had a very sad story. Fortunately, I have 3 babies, so for me, that was my 3rd baby. And I was in a very good facility, because if I can mention, I was in Kampala Hospital, where I thought, okay, everything is okay. The team that walked me through the 9 months was very good. But when I went for my last antenatal, I didn't find my doctor, so they told me this was an emergency and I needed to go to theater right away. Actually, they even put the catheter at triage. They gave me a catheter, put me in a wheelchair, put up a line. They wheeled me to theater. So I was very frightened, because I'd just come to have my antenatal, normally go back. And reaching theater, they had even called the doctor who was in theater not to get out before he works on me. But when we reached there, the doctor had left, so I had to sleep on the theater table for another 1 hour before he came in. And when he came in, he said, can you take off that lady? Because I'm not working on that lady first. There's another lady I want to work on before I can work on that one. But even as they were wheeling me to theater, I told them, can you please give my file to this doctor to read through and get to know my history? Because I knew he wasn't my doctor, and he's going to see me for the first time. Yes. And they comforted me and told me, yeah, we shall give him the file. So he comes, says they remove me, and then he goes out. He was on social media that time. I got so scared because I had already been scared. A doctor going to operate on you, but the first thing is there's come into the room, doesn't look at your file, but rather on his phone, he's on social media. Doesn't even know the name of the patient. And he doesn't know you're anemic. No. He didn't even know I had sickle cell. I imagine, because he had not read my file. What happened next? So he goes out, then eventually comes back, and then the anesthetist said, no. When he stepped out, you lady, you've been very strong, and the lady he wants to work on, the baby has already died. I see. So I'm not going to let your baby die when I'm here. Can I give you the medicine? Then when he comes, he has to work on you first. This lady, I really respect her and thank her so much, because I think she was one of the my time changer that time. Indeed. So when he came in, he said, I said to remove this lady and I work on the other one. Then this one said, but I've already given her medicine. So he just grabs whatever machines they use and comes and opens me. A month or two months before, they had done a scan, and I knew I had a breech pregnancy. So they told me it was C-section, so I knew I had a breech pregnancy. So when he opens me, he jumps in fright and says, oh my goodness, this is a breech pregnancy. So when he makes that comment, it was a spinal. So I was hearing everything. I just knew I am finished. Because 1, he doesn't know I have sickle cell disease. 2, he didn't know. And he first jumped away, then he comes back to grab the baby, gets the baby out, and the baby cried so badly. And when they showed me the baby, I had never seen that color before. I think the baby had either turned navy blue, you don't say, black, I don't know. Because when I saw the baby, my brain registered that it was a stillbirth. And at that time, I gave up everything. So I had registered that I had given birth to a dead baby. So I gave up. The pressure was going low. the oxygen. They started panicking. They brought monitors. They plucked monitors. They started injecting me. Others were beating me. Ruth, we don't want to lose you. You've been okay. And I just knew that everything was wrong, but I was looking at the monitor and I couldn't communicate back. Until when one of them asked me, what is the problem? Then I answered in a very faint voice that my baby. And then this one told, no, your baby's fine, your baby's in a nursery, your baby will pick up. But for me, I could not take that until I think, yeah, it was too much for me and for them as well, because they had to go outside and call my husband.
All right.
And now when my husband comes in, starts talking positive things, he's the one who picked me up. But during the process, now my child sustained 2 fractures. The baby got a fracture on the left hand and the right thigh, and this was not disclosed to me. I was in hospital for 4 days, discharged very well. The baby was not breastfeeding. They told me to buy milk. The baby was not taking the milk, probably because of the pain, but nobody told me. And it was my mother at home now bathing the baby, and my mother said, I think this baby has a fracture. Can you go to Mulago? Me, I trust Mulago. So I go to Mulago and they scan the baby. They did an x-ray, then they tell me the baby has 2 fractures.
Wow.
Yeah.
That is Ruth
really
Nakanja. That is a somber story. She's the executive director of the Sickle Cell Association. Of course, her story, yes, is actually something many people are talking about, especially in the rural area. So she was in a private facility. She couldn't get this service she was looking for as far as maternal and newborn care is concerned. But what about the women within the rural settings where there are no health facilities in that regard? We do know the COVID-19 pandemic did wreak havoc. When they did call for those lockdowns, people could not move from one place to another, meaning mothers could not go to those health centers. Now, in the rural areas where these health centers are non-existent, the deteriorating situation was actually compounded by that fact, meaning many of those mothers had to give birth in their homes using local doctors. Dr. Olive Sembutia Mugisa, how rife did this trend actually take center stage during this COVID-19 pandemic? Mothers giving birth in the confines of their homes without quality maternal and newborn care. Is this the reason why we are here, talking about these increasing rates of mothers being lost, young newly borns being lost during and after birth?
Thank you, Romeo, for raising this.
Indeed.
As we have agreed that mothers and their families, of course, in the immediate lockdown periods, there were major challenges for them to move from their homes up to the nearest even level of care. Health workers did not move away as such, they remained, but they were also challenged in the kind of systems they have to put in place at a very fast speed to ensure that they prevent infection in the health facilities. The government of Uganda, I recall, and we will all remember, that they used to hold daily meetings to address the challenges that were coming along with the standard operating procedures for COVID. And times health workers, their leaders at the Ministry of Health would raise the issues, and these issues would go higher to where the commanding post was, which was ensuring that these SOPs are sustained. And they would keep changing. But remember that it is a total system lock.
Indeed.
And so it cannot recover. The transportation system cannot recover. But neither the logistics system, which allows health workers to receive what they need to receive on a daily basis and address the numbers that must keep coming.
Mega resources on their part, health workers.
Yes. But also remember that many people lost their jobs. And they could not have the resources that sustain them in healthcare, because couples, individuals, families have to make sure that they transport the woman to the health facilities If there is fear, even before the pandemic, there was even greater fear. Because if the family does not have the resources to transport and there are security, tough security measures to be addressed, and there is a system to ensure that you walk through it with the announcement, regular announcement of what needs to be done by the districts to ensure that a system, an emergency transportation system is put in place. We know that many mothers delivered in their homes. Some of them were successful, they could deliver, but others who definitely had to be picked up by the system faced major problems to access the service when they realized they are bleeding, the baby is not breathing. Those who normally, anyway, the 15% which develop complications really faced it rough. But we also know that some of them even tried to access, they got problems, some of them got problems on the way, on the borders, lack of taxis to take them. But even when they eventually managed to come,
there are no services.
You come at a level which cannot easily manage you, and it asks you to move on. Now, when they ask you to move on, the system which moves you on to the higher level of care where you can be managed has not immediately been activated. Except in Kampala, we saw an active emergency transport system for the mothers. But it can't also pick everybody because the population need is very big. And it didn't stop that because there is the pandemic, for us our processes must stop. No. That means that there was a disruption in the normal flow of service delivery. Remember, some health workers also couldn't move. They are part of those people who cannot move easily. They are part of that group which is frightened. They are part of that group which hasn't yet accessed their resources to enable them arrange private means of reaching where they need.
But guess what? Even those individuals who needed the help from the medical workers, after reaching these health facilities, there was no medicine for them. Well, there were no services for them. So they lost faith and they said they resigned. Why do I have to go back?
And you're saying exactly yes. Because the health workers not reported in the normal way. So even if the medicines are there, this person who needs to give it to you.
So I have to resort to the local midwife within my area who is not experienced, who is not trained at all to handle my pregnancy.
Because it must come out. Once a woman is in labor and is second stage pushing, it must go.
Those are the deaths we are talking about.
Yes. So you resort to the nearest service that can help you.
Dr. Olive Sentumbwe Mugisa, let's also talk about some of the other push factors leading to these deaths that we are talking about. Perinatal deaths, neonatal deaths, and also maternal deaths in that regard. What are the other push factors besides COVID-19 and rude midwives?
Thank you. As you know, overall in the world, there are direct major causes of deaths in mothers because of their pregnancy. Because we know, and we should inform you, that every pregnancy carries a risk. Each pregnancy is different. It doesn't look like the other. You could have succeeded first, second. But we saw third one becoming complicated with things which you do not expect. And you can even deliver normally, normal baby. And one of the biggest challenges we have in this country is bleeding after birth, excessive bleeding, which is not expected. And probably the system, as you recall, still, we have insufficient amount of blood in the system to manage our obstetric emergencies due to bleeding which comes after childbirth. So those are known, and the systems must get prepared to address them. But even as they get prepared, you cannot blood. It's not a commodity we buy. But we need people to donate blood. We have not sustained the same numbers of people coming in to donate blood. And you know very well that this was coming in from mainly students who are
at home,
very healthy, but now they're at home. Let's move to another complication. The hypertensive diseases of pregnancy, which are very fast to cause you a problem. You can develop a problem on Wednesday, and each hour that passes, it just keeps worsening. And yet, for us at the community level, probably over 90% of women and their husbands and their mothers do not know that this, what the mother is describing, is a danger sign. That she has developed a headache, she's dizzy, she feels pain in the abdomen. They can delay for several hours, which actually mean that you're moving into a non-reversible state. And by the time you say, let me run, you reach the hospital, the system that needs to put you back with your child may not work as fast because you've already deteriorated. So hypertensive diseases of pregnancy are very high on the agenda. We are now seeing also, as we have seen before, complications of abortions, whether spontaneous or induced. When mothers lose this pregnancy prematurely, they develop various types of complications, and you must be taken to a health facility which can help you not to bleed, not to go into infections very quickly. But for many mothers who bled out there, it is not possible to access a service quickly, and when you access it, we must put into, motion all the systems to act. We lose mothers due to ordinary medical complications, as you heard. Sickle cell is one of them, but we have malaria, real, because for many mothers, they are not taking the recommended Fansida per month. Per month, they are not coming in for receiving the antimalarials which prevent this malaria to be very destructive in pregnancy. And so we are calling upon mothers really, attend antenatal care, get the health worker to make sure that they are detecting what could be an ongoing problem, but also practice what is recommended as quality antenatal care.
Dr. Olive Sentumbe, thank you very much for that submission. She is the Family Health and Population Advisor at the World Health Organization. The key word here is mothers, but then the other contestation that is coming through pertains to young mothers. Could that be the reason why we are dealing with so many maternal mortality rates within this country? The fact that the mothers we are talking about are actually teenagers.
Yes.
When we talk about the skyrocketing teenage pregnancies during this COVID-19 pandemic, this is exactly what we mean. You have a young mother, she's inexperienced when it comes to childbirth in the wake of poor access to maternal and newborn health. Let's also compound more on that conversation with, that is Ruth Nakanja, the Executive Director for the Sickle Cell Association. Ruth Nakanja, yes. Young girls, teenagers have become pregnant in their thousands during this COVID-19 pandemic. Could that be the reason we are talking about the skyrocketing number of maternal mortality rates, perinatal deaths and also neonatal deaths in that regard?
Yes, I believe so.
Because these are not our regular mothers we used to deal with.
They are not, and secondly, they are fearing, and then sometimes the husbands are also as young as them. Others are irresponsible. The perpetrators, yes, actually, because they are underage. Yes, you're right, under 18. And some parents are also not ready, like, to support them through. So the kids don't know the system. They don't even know where to begin from, so they are scared. It takes time for the adults to get to know that these kids or babies are pregnant. So yeah, that has contributed a big percentage of mothers dying. And of course the issues of blood is very big, because we know the school children are the major donors of blood in this country. So if they have been locked down for these 2 years, and we know it's not only the mothers that are using this blood, the accidents, the emergencies,
now the children
the
themselves
other
who used to offer the blood need it.
They need it, and it's
because
not
they are
there.
now pregnant.
It's not manufactured. Yes. So it's a whole heap of issues that has contributed to these deaths. And I think we need to really come up as a country and put a better, well-organized, well-representative for everybody, because COVID-19 is here with us and it's not leaving tomorrow. I think it will be here maybe for 20 years.
Indeed.
Because this is how HIV came in. We first thought, no, that family was bewitched. We were young, but we used to hear people saying, but we've been with HIV for 40 years.
Ruth Nakanje, we can go on and on about improving access to maternal and newborn care for our pregnant mothers, but then who is making them pregnant? That is a question leaders should be asking themselves. You understand what I'm trying to say?
Yes.
If you can, you know, stop the fire from the problem, then we wouldn't be here, because right now we are focusing on the smoke, which are the pregnancies that have taken center stage. But who started the fire? They are the men, the perpetrators who have been raping, who have been defiling these young mothers, hence making them pregnant in that regard. Now, you look at a situation whereby a father is raping or defiling his own daughter.
It's a shame.
How will she actually go to report to the courts of law or police in that regard? Because in most cases, the father is the breadwinner. So she doesn't want to report this case, meaning she'll just have to grapple and accept what is happening to her, become pregnant, carry the baby on behalf of the father. Now, this is what would happen, because you're thinking, they will take this child to the health center. No. Since the father doesn't want to be ashamed of what he has done, they will actually call a local midwife to come to the home to actually operate on the child during that delivery. And we all know what would happen, death in that regard. And when these people make it to the courts of law, what happens? The courts of law say, please go outside the court and mediate.
Negotiate, mediate.
So the perpetrators know, if I defile someone's daughter, they will take me to court, but I'll mediate outside of court. If I have money, I'll walk away scot-free. Are courts of law also to blame, the judicial system, for this heinous problem that we are grappling with? Because we did even author a story today whereby in courts of law, victims were being asked to open or present their genital parts as evidence. Is that even possible? Would you even do that? Are all these factors put together, you know, bringing us to this major problem we are talking about?
Yes, and I think before we even go to the courts of law, even us as parents, I think as parents we have actually neglected our responsibility. Yes, I appreciate kids have been sent to us, but these kids are not for government, these kids are not for everybody, they are for us. So I think we need to make these kids our friends, we need to make them as busy, we need to know what is going on with their lives, they need to share with us. But I think what most parents have done, they buy data for the kids, they give them the tablets, they give them the food to eat, and they have shut down. Thinking these kids belong to the school. So the system has actually shattered right from home. And then when you look at the courts of law, yes, the police themselves, the LCs, everybody, I think we are all to blame. The community. Formerly, when we were growing up,
we were raised by the community.
Everybody, the community, you were concerned if something happened. Why are you looking like this? Why are you doing this? But today you see someone's kid, just your neighbor, you drive off and go, you don't say anything. The next thing you see, this one has gotten HIV, or this one is pregnant, this one has died, and then you come in to sympathize. I think everybody needs to come up. Yes, government has a bigger role to play because they have the resource envelope, they have the authority, they have the mandate, but also us, we can make a contribution to really change this, because I think our kids are really dying away, and we don't know when this will end. Maybe it's not ending tomorrow. We are hearing of a third, fourth wave. So we need to be prepared, and we need to support these children, for their mothers. Please, please, and please, no man has ever died from a labor ward. It is us who die from there, or the kids die from there. So the mothers, we need to step up and send these perpetrators to courts of law. We take them to prison, we take them to court, so that at least we can prevent others from getting the same
Do you
problems.
think courts of law would be able to help? We are talking about the judicial system that will tell
asking
you, please
for genital
get out of this court and mediate
and actually
from
that
outside.
makes you shun court. You won't
We are looking
even
at
go
victims
there.
refusing to go and report these cases
That's
simply
very
because they don't want to be
unfortunate.
ashamed in the courts of law.
It's a shame.
policies.
It's a shame. I think we need to change our policies.
Indeed.
Yeah.
Of course, we are talking about World Patient Safety Day, which was established in 2019 courtesy of the World Health Assembly. Yes, it should be celebrated every year on the 17th of September to raise global awareness on the issues affecting maternal and newborn care. The theme this year is safe motherhood, that is safe maternal and newborn care. And the slogan for this year is actually Act Now for Respectful Childbirth. That's what we are talking about. In Uganda here, out of every 100,000 women giving birth, 93 will die. That is against the Newborn Action Plan of the United Nations that calls for at least 34 women dying. They say at least 34 should die out of every 100,000 women dying during childbirth. And how many young newborns die out of every 1,000 live births? Yes, in Uganda here the number is at 20. It's against the Newborn Action Plan of the United Nations of at least 10. They say at least 10, under any circumstances, 10 children should be dying during birth in that regard. So Uganda is losing this battle, left, right and center, as the government and its officials continue to slumber. Dr. Olive Sentumbwe Mugisa, she is the Family Health and Population Advisor at the World Health Organization. We want to talk about the ramifications that would befall any jurisdiction that doesn't invest heavily in maternal and newborn care. What are some of those implications, Dr. Olive?
Thank you, Romeo. I think it is going to be important to appreciate from the previous submission that we have things to do within the Ministry of Health as a part of the health sector.
Indeed.
They need to really invest in the building blocks of the system.
Yeah.
The infrastructure. We are moving, as you heard, with a level of unexpected 2 million births. But as changing infrastructure and building it to absorb this kind of population growth, the investment in the infrastructure needs for mothers and newborns being delivered is not at the same pace. So we need to invest in the behavior as well of people, because government has brought into place the whole area of family planning with a wide range of availability of different contraceptives. So as we work in the health sector to provide blood, to provide equipment, medicines required, the number of health workers who are trained and retooled to address the respectful care we need to give. Our production, our investment is not yet at that total population, I would say, crisis which we are facing. We need to therefore address the factors in the community which will address also sort of controlling at the rate which we are putting this issue to the health sector. Mothers and their husbands and their partners need to realize that they don't need to be pregnant all the time they are procreating. They need to use contraceptives.
Indeed.
Children
to prevent the pregnancies.
Yes, to
so
prevent.
that we don't end up in this state of quagmire where young mothers are actually grappling with these pregnancies because they haven't reached that age. Go ahead.
So we must engage at the level of the culture sensitivities,
The religious leaders.
the religious leaders and their norms,
The resistance against contraception.
all that coming into perspective now. Really, we have now an opportunity to know that unwanted, unplanned pregnancies are causing Uganda a huge problem.
Dr. Olive, demystify some of the misconceptions surrounding contraception. You'll hear one too many times religious leaders saying they are detrimental to children's or any woman's health. Is that true?
Fortunately, anything you'd like to think about, as you know, even Panadol,
Indeed.
can give you some side effects. In fact, we call them side
Even
effects.
aspirin.
Even aspirin. Even antimalarials, we react differently. Before a contraceptive comes on to the market for use globally, they are tested. They've gone through all these clinical trials and determined that this is a safe commodity to put on the market. they can also be sued. They're not just manufacturing without going through a system which clears the safety of the contraception.
Yes, sir.
And then we make sure that we teach health workers how to handle the side effects which can happen. Because as I've said, anything can give you, even food. You have eaten food and yes.
Cold food can give you poisoning.
Yes. But even the matoke hot, you have enjoyed it. Many after that they say, I have a dyspepsia. So come to the health worker to address that complaint you have. Come to a health worker. Don't listen to your friends because they didn't study contraception. When there is a problem, the health worker can address it, change you to another method, because we don't know also which body will react to what. So please encourage those who are supposed to be pregnant to delay their pregnancies for at least 2 years before they think about another pregnancy. But for the children, please, we have to give them a lot of sexual and reproductive health information and services. You've heard that the families have sort of disintegrated, the behavior has changed. And we need to talk about also those transformations that need to be addressed. Why would a man of 25, 26 up to 30 have sex with a child?
Indeed.
These are behaviors we must address at the community level and know that they are resulting into A, B, C, D. But this discussion must happen at the family level, as you've had, must happen at the community level, must happen at the district level governance, and they establish their own local systems to address this. And they say no to some of these behaviors.
Another significant consequence of unhealth care for our mothers is the psychological cost to the families and the patients in that regard. Compound more on that.
Yes, you've heard very well. And actually, this topic of respectful maternity care is a standard that has been set now globally. That as we work towards increasing the availability of the physical services we give, we also as health workers, right from the beginning when we receive the mother in the antenatal care period, we must address that mental health, that psychosocial health, that counseling, that friendship. The attitude must be so friendly to a mother because pregnancy is already a mental challenge. You're pregnant, you are stressed. You have a lot of thoughts every day about what will it mean, how will it change my life. You have also an environment which you're not very certain about. Your husband is doing ABCD, you've lost your job. So there's a lot of mental health stress within pregnancy itself. So the standards require us as health workers to be retooled in that area. To change our attitude, which is now a global problem, and the World Health Organization and all UN sister organizations have agreed that we need to retool our health care service, our health workers, to begin to be very empathetic, to begin to be very friendly, to dignify mothers and their families, to give them the respect they need according to their own issues. And so it's something we must now adopt. We must change our systems, and we must bring on the mother and her family. And
also bring on the government, Dr. Elif Sentumbwe Mugise. He took a constitutional court ruling for the government to increase more budget funding to maternal health care. You did see that coming through. I mean, where do we get the confidence that this time around government is going to wake up and, you know, work on maternal and newborn care, safety and interventions?
Thank you, Romeo. Government, whenever we think about government, we think about our leaders in their different levels. The parliament, to start with, has to be made reactive to this problem. But how do you create that awareness, which needs to be created, and make sure that the costs involved are properly defined, so that the representatives of the various constituencies, those are the MPs, begin to take this as a priority area of work within what they've said they will do for the people. We need to put it as part of their political agenda. And we need to make sure that the communities demand that there is a discussion between their leadership, because the decisions made in Parliament influence the investment. And if that is going to happen, we have a huge job to avail the data you have been beautifully talking about, the Ugandan data as it is. Remember, we have given institutional deaths, institutional births, but the system in the community now, we are not exactly sure what numbers we have. So once we've put that together, and every district has this capacity to get these specific numbers and make sure that their leaders are aware.
Indeed.
That will be the beginning of accountability systems, of transparency at that level, and then they can take it to the highest level, the Parliament. But the communities, the mothers, the fathers at the family level, this must be a topic of regular discussion. You're pregnant. Have you gone? Shouldn't you go tomorrow? I have some transport, please go. So that each of us plays their role. We have a role to work with those community resource persons, because we are few in health. The skilled workers are very few, but have we sensitized the community health workers to also do their part and mobilize mothers into the system with their husbands? To make sure that once you start labor, pain, you must run. We are seeing very many mothers. They have started labor now. We will not see them until tomorrow.
Indeed.
So we are now embarking on a system, and yes, we are slow, but also the investments needed are still inadequate. But thanks to the development partners, they're all coming in. We must have a community arm of the response and a systems response in the health sector. But where is local government? What about the transport and communication? What about the power for the health services?
Yeah.
All these people must come together to mount a multi-sectoral response where we all input.
All right. Dr. Olive Sentumbwe Mugisa, she is the Family Health and Population Advisor at the World Health Organization. We are talking about World Patient Safety Day in this regard. In Uganda here, we did lose some 1,085 mothers during childbirth, that is in 2019. And in 2020, we did lose that the mothers, the number increased to 1,202. In Kampala here, the number was 97 in 2019. It increased to all the way to 185. That is in 2020, and most of those deaths occurred at one hospital, that is Kawempe Regional Referral Hospital in that regard. So how best can we reduce the maternal mortality rates? How best can we reduce the perinatal deaths, the number of children dying at birth, and neonatal deaths? The number of children are dying after birth. We have so many push factors leading to the deaths of children, perinatal deaths, and also neonatal deaths. We are going to be having Ruth Nakanje explaining some of those push factors and some of the resolutions we could put together to reduce these deaths from taking center stage. Ruth Nakanje, perinatal deaths and neonatal deaths, because we've largely been talking about maternal mortality rates. What are some of the push factors behind these deaths?
Yes, I think some of them are that some of the community structures, like Doctor has been mentioning, are not used actually, because Uganda has a very good system of community structures that are sometimes not used, because we have right from health center 1, which is the village level, where we have the village health teams. If they came on board and probably identified all the pregnant mothers or those that need contraception and the young children that are getting pregnant, if they could identify them at that level, give them information and refer them, that could reduce a lot of some of those deaths and numbers that we are talking about. And then we have at health center 3 level, because that's where delivery begins at ministry or local government level. There is a community structure still there. What is called the HUMIC, Health Unit Management Committee. They are meant to be sitting on a quarterly basis. If they could be sitting and doing the maternal audits at that level and get to know how many babies have died, how many stillbirths, how many mothers, and those reports are taken up to the district level, I know this will influence even Parliament. Because if all these numbers come right from health center 3 level upwards to Kawempe here, where we are talking about, we would be having all the figures and would be on a strong basis to push our MPs to say, okay, this time round you're not passing this budget probably unless you have added this. Then we need to go back to the training schools and put in the aspect of empathy, put in the aspect of the positive attitude, put in the aspect of the health workers knowing that they are not dealing with machines when they are delivering these mothers, because you cannot come in theater, you don't even say hello, you don't even know my name, and you just begin opening me. At least say hello, it's a nice breaker, and then get to know me so that we can start our process. But if you scare me off and you're like, you're operating a stone, this alone is enough. If I'm not empowered enough, probably next time I'll never come back to any facility. I'll go to a traditional birth attendant. Secondly, the issue of disclosure. If something has happened, we are not going to courts of law, fine. We know mistakes are done. Tell me that your baby got a fracture during this delivery. Why do you keep quiet? What if this baby gets sepsis along the way and probably the baby passes on? You have contributed to that. Yet we are supposed to be putting the casts, probably treating the wounds and the fractures, and the baby gets better. But you imagine a baby getting the casts after 8 days. No Panadol, nothing, the baby's just crying. I think this is unacceptable anywhere in the world. Just communicate, tell me, okay, there was this problem, probably this is how we are going to solve it. I will take it because I'm human. So how can we even change that? Some things, it's about the referral system. Talk about the referral system. They refer someone, then they start, the ambulance has no fuel. There's no fuel, or the tire is not there, or the driver went somewhere. So all these are contributing factors that we are not seeing. Then when you come to the household level, Doctor talked briefly about the delays. There's the individual delay whereby I have started labor, but I don't even disclose to my husband a whole day, and probably tomorrow I disclose. Then the husband starts saying, oh, I don't have money, first wait, let me first sell my goat, then you go. So you can imagine by the time you reach at a facility, you have gone to a health center too, they tell you here we don't deliver, can you go? So all these are contributing factors to some of these things.
And of course there are other factors like birth asphyxia, respiratory failure, and so forth that Dr. Olive Semtumbwe can expand more on, besides the environmental factors. Go ahead.
Thank you very much, Romeo. We know that the direct causes of death are these medical clinical things, which we know.
Which compound the significance of antenatal care.
Exactly. Now, there and then in labor, during labor itself, how many midwives, how many workers are on monitoring how this pregnancy is progressing, how this labor is progressing, and how is the baby doing? Is it getting bad as they manage to detect for our colleague, and quickly rush in, to get your baby out? So that system which allows a system to pick you quickly and do the necessary intervention in time is something that we must focus on.
Dr. Olive Semtumbwe Mugisa, she is the Family Health and Population Advisor at the World Health Organization. I'm afraid we've run out of time. Many thanks to you, Ruth Nakanja, the Executive Director of the Sickle Cell Association. Thank you very much for having made the time to speak about this very pertinent issue on this very auspicious day, World Patient Safety Day. We'd like to leave you with this message as NMG, that the cost of prevention is much lower than the cost of harm. Have yourselves a blessed day.